Over to you, Ranjith.
Yes, it's recorded. Could you please
Afternoon.
play the recording?
At the outset, I wish to thank ASSI and the Indian Orthopaedic Association for an opportunity to present at this mini icon at Jaipur. So, in this session, we will discuss about post-operative neurodeficit. So, this was a 64-year-old gentleman who came to us with cervical myelopathy, difficulty in walking. This was his MRI. Nothing unusual, a classical picture. Elderly gentleman comes with myelopathy, difficulty in walking, gait disturbance. So we decided to go ahead and do a posterior laminectomy with a lateral mass fixation. This was just immediate post-op X-rays. He had a good post-op recovery. Immediately after surgery, he was told that his pain has got better. He started walking. After 6 hours, he began to complain about some vague weakness in his upper limbs and lower limbs. At which point of time, we started the usual thing of steroids and saw what is happening. So he gradually worsened, and by around 8 hours after surgery, he became quadriplegic. At which point, we immediately took him and got an MRI done. And this was the MRI picture. If you see very clearly, you can see that there is significant cord compression. And this was a gel form or an ab gel which I had kept in the laminectomy defect. It had expanded and it had compressed the cord. And that was the cause of his deficit. Now, what do we do? Why, what and why did this happen? So this image told us that, well, the cord has been compressed and that has led to this deficit. What do I do now? I think in this case, the answer is quite obvious. Go ahead and remove it. Now, how do I tell the patient and the family that what has happened, that he was recovered and now he has become bad? What exactly is the sequence? Now, how do I tell the family? How do I convey the bad news or break the news? Now, if I go ahead with surgery, what are the chances of recovering back to his pre-injury or pre-operative status at least? Now, in this particular patient, we went ahead and as emergently possible, went ahead, removed his pressure on the cord, washed it out. And this was the immediate post-decompression, repeat decompression MRI, which showed that the cord had decompressed. And he gradually improved, but did not reach his post-operative status. And after a couple of years, he died due to other reasons. So quite an unhappy experience. Now, what do you do when you have these situations? Number one, do not lose your temper, because you getting mad makes the whole team lose the temper and you will not end up with a solution. What do? First, a quick and pertinent analysis of the possible causes, immediate remedial measures as into steroids or avoiding hypotension or improving the blood pressure, and to plan a post-operative imaging at the earliest. And most important, mind management. You are the one who's going to convey the news to the family. It should be you and nobody else from your team. And you have to get them to consent, because most of the time we might need some procedure to be done, because you cannot have a deficit without a reason unless you have something like a vascular injury where re-exploration might not help. So what are the possible causes? Look at any events during positioning. You should know that which level, or you know that cervical and thoracic are more probable of having deficits than lumbar due to obvious reasons. Review the anesthetic events pre and peri on intraoperatively. Did you have any hypotension or untoward cardiac changes? Review your surgical steps. At any point of time, did you ever cause any neural tissue damage? Did you pull on a root accidentally or a kerosene hit on something? Or do you have a dural tear? Were you sure that did you adequately decompress the cord or the root, or is it possible that a cord shift which has happened after laminectomy has caused excessive traction on the roots? Did you have any interop event where you had accidental pressure by your instrument on the dura? Did you have any pedicle breach or screwdriver slippage while doing instrumentation? Did you have any change? Was anything untoward when you position the patient, like you do a front and back in the same sitting? When you teach it over, did your neck turn abnormally or anything like that? Go through all these causes. Now, here, what do you do? So, there has been very debated evidence of giving steroids at the so called high doses. Well, I use it for want of something, if not contraindicated. And without delay, you have to plan a post operative imaging, might be an MRI or a CT or both, as the case may be. Please communicate with the radiologist as to what to expect, what happened. Please convey to him, did you have any intra-op unusual events? Be bold and to face up the imaging outcome. If you're told that, well, you have caused a vascular injury, be bold to face it. Now, what are the causes of post-op neurodeficit? Most common is mechanical compression by epidural hematoma, by or a root or cord compression by pedicle instrumentation, by surgical trauma or neural tissue handling, by compression distraction, especially in deformity corrections, or instrumentation errors like a pedicle violation intraoperative, and very occasionally vascular ischemia of or cord ischemia, especially in hyperkyphotic thoracic spine deformity corrections. It's been reported and also debated. Now, how do you manage the situation? Be honest with the patient and family. This is where you have to be very clear that this has happened. Let us see what we can do. You have to stratify the cases according to the diagnosis and the procedures. When you're doing an OPLL or you're doing a high-grade listhesis or a CBS scoliosis, you know that there's a more probability of having a neurodeficit as compared to a lumbar discectomy. So when you do your pre-op counseling and consenting, be upfront and very clear about them and document it. You have to break the news to the family in the event of the deficit with composure, concern, and not an element of brashness. Don't disown the deficit. Don't, at the same time, you can be very clear that I don't know why it happened. Let us see what we can do about it. And be very honest, and that really helps in a long way too, because the patient might not stay with you for your further procedure, but be very clear, and honesty helps a lot in that situation. If you look at literature, a good review from Dr. Keith Bridwell's group, where negative impact has been found on the ultimate patient-reported outcomes in the event of neurodeficit, which is quite obvious. Around 9.9, nearly 10% of patients who had a deficit were unhappy in the long run. Now, this is an interesting review from a single center where the incidence of neurology complications over 10 years were studied. This is published in the JSDT, where 11,817 adult spine surgeries were reviewed, in which 21 patients had a neurodeficit, a very minor incidence of 0.178. Mind you, this is from a spinal institute with a training center where probably expert surgeons are operating. So it's a very, very low incidence. Among them, the maximum number were in the cervical spine, followed by thoracic, and the least in the lumbar, as you would expect. In their series, the most common cause of post-operative deficits were epidural hematoma in a vast majority of patients, followed by inadequate decompression, vascular compromise, supposedly, surgical trauma or intra tissue handling, and cage displacement. Among them, a vast majority of them had instrumentation. So adding of instrumentation has known to increase the chances or incidence of post-operative neurodeficit. Another illustrative case of ours, a young lady who came with a foraminal disc with arm pain, neck pain, unending arm pain. We went ahead, did a posterior cervical microforaminectomy, a tube-assisted surgery. The patient woke up after surgery with complete pain relief, but weakness of her elbow. We went ahead did an immediate imaging because I don't remember having any untoward, even intraoperative, but we could not find. This imaging is showing that this is just fluid in the post-op space. Being endoscopic procedure, because there was no much of tissue edema seen, since we did not find any obvious cause, we sat on her and she eventually improved. So we did not have any qualms about going and imaging her immediately post-operative. Now, another interesting review by Professor Fellings and his team, where a large number of published articles was reviewed regarding the iatrogenic neurological deficit after lumbar spine surgery. They found a very high incidence, almost 9% incidence of deficits after lumbar spine surgery, out of which a vast majority were after A-lifts, followed by lateral lumbar interbody fusions, followed by posterior. A very little had after posterior surgeries, thankfully. Another review by Biden, who reviewed 500 microdiscectomies, found 2.61% incidence of post-op weakness. So that means among 100 patients of ours, at least 2 or 3 of them would end up with a post-op deficit. So that's information which we should be armed with and be able to consent our patients with. Another patient of ours, when you end up with these kind of high-grade listhesis, wherein you are going in and doing, this particular patient of ours wanted a reduction due to cosmetic reasons. So this, we did a lumbosacral osteotomy. So in this case, we had wanted that she might end up with a foot drop, and she did have a bit of a dorsiflexion weakness, but she never complained because she was totally prepared for it, and she totally recovered by 6 weeks. So planning and consenting and letting them know this can happen helps a lot in going through the deficit. And what are the outcomes of re-operation after a neurodeficit? Again, from the same paper, nearly 35% of them have complete recovery. A vast majority, 2/3 of them, don't recover completely. Of it, the most common cause were epidural hematomas. 0.1% of them needed evacuation. Now, there's a debate regarding the use of wound drains and hematoma formation. We'll not go into that. So to conclude, it is best avoided a post-op deficit. Please be prepared on a case-by-case basis and know whom to warn and what to expect and consent them appropriately. Be very cautious in use of instrumentation. There is evidence that use of intraoperative neuromonitoring as well as navigation can decrease the incidence of neurodeficits. It's probably not available to all of us. If you have it, very good. Use judicious use of post-op imaging when you face with the deficit. Mind management in breaking the news is very important as much as managing the case. Honesty is a very good virtue in these situations. Thank you for your patient listening. Be ready to face the deficit whenever you face it. Thank you.